Hemodynamics in surgical practice. Introduction. In medical context, hemodynamics is often referred to basic measure of cardiovascular functions, such as arterial pressure, cardiac output, and cardiac output. Hemodynamics is the physical study of flow of blood and all the solid structures, such as artery, through which it flows. There are numerous biological process elements that interact together to sustain homeostasis. All the details of such processes will not be discussed for this, will not be the main goal of this discussion. Of course, we just focus on hemodynamics monitoring and then management in the surgical practice. Monitoring of hemodynamics, this involves measurement of blood flow, its pressure, oxygenation within the cardiovascular system. Hemodynamic monitoring is required, particularly in patients undergoing surgeries and critically ill patients. Appropriate hemodynamic management is a critical component in the perioperative management, in perioperative care management. Surgery can induce significant response, which may vary based on the condition of the patient, the type of surgical intervention, the type of the volume of the blood loss. The physiological changes in perioperative period may lead to capillary leakage, redistribution of fluid, sodium pathway disruption, leading to loss of retention and a significant metabolic change. Anesthesia also has potential to induce vasodilation, halter cardiac function, and the use of muscle relaxants will lead to vasoplegia and vasodilation. So this is a complicated subject, and appropriate hemodynamic optimization of the patient during the surgery, it cannot be overemphasized. Of course, hemodynamic itself does not, monitoring does not, is not just enough to say you are monitoring hemodynamics of the patient. Other protocols has to be combined together for positive patient. The goal of hemodynamic monitoring in care management, the goal are to ensure there are adequate perfusion, tissues, and organs, and then to ensure there is early detection of problem associated with disruption of hemodynamics, and then for the purpose of titration of therapy, and then to differentiate among various organs system dysfunction. Hemodynamic management refers to intervention or therapy that is aimed to maintain a certain level of cardiovascular blood flow and pressure. The intended result is adequate tissue perfusion, oxygenation in the presence of surgical, and oxygenation in the presence of surgical stress. Hypovolemia and hypotension leads to reduced organ perfusion and postoperative complication. On the other hand, excessive blood volume administration or fluid administration can lead equally to poor outcome. Thus, the goal of anesthesia provider is to find a proper balance between the hypovolemia and hypervolemia to maintain a state of to maintain an evolemic see. Changing the fluid management practice in the whole heart and clinical evidence, particularly in the setting of enhanced recovery after surgery. It's an emerging concept for us, especially in this part of the world. I know people out there in the West and the Europe will be more conversant with this. The changing fluid management practice in the operating room and clinical evidence, particularly in the setting of enhanced recovery after surgery pathway, I've created questions and debates surrounding the potential of intraoperative fluid and hemodynamic management strategy for surgical patients. You know, before the emergence of this concept of enhanced recovery after surgery, we have traditional pathway wherein patients are subjected to like 12 hours of fasting before the surgical procedure. Of course, you know, these have implications for homeostasis of the general physiological homeostasis. For instance, this partition table presentation structure I have here demonstrating the enhanced recovery pathway and traditional way of approach to fluid management. Of course, the aggressive fasting of the patient, it's what is traditional, but the enhanced recovery after surgery is introducing, trying to push the boundary to go as far as allowing clear oral fluid up to 2 hours before some surgical procedure and modify intervention, such as preoperative interventions such as joint exercise for 4 weeks, lungs function exercise, or modify form of analgesia, and they're using opioid as sparingly as possible. Whereas when you compare and contrast, there's a a kind of significant departure from the traditional system or method or pathway that we have been used to. Enhanced recovery after surgery, ERA, were developed with the goal of maintaining normal physiology in the perioperative period, thus optimizing patient outcome without increasing postoperative complication or readmission. The basic principle of ERAS include attention to the following: preoperative counseling and nutrition strategy, including avoidance of prolonged perioperative fasting. Perioperative consideration include focus on regional anesthetics, non-opioid analgesic, appropriate fluid, and maintenance of normothermia, and promotion of postoperative recovery strategy, which include early mobilization and appropriate prophylaxis. Benefit of early recovery after surgery, improve postoperative pain management, and the need for improve rapid return of bowel function, and decrease complication and readmission rate. Readmission rate. So, implementation of ERAS protocol has been shown to increase has not been shown to increase readmission or mortality in the perioperative patient. However, fluid fluid requirement may be somehow different in a ERSA setting when compared more to traditional perioperative care. The two concepts in the perioperative fluid and hemodynamic therapy and the overreaching focus of the overreaching focus of this discussion, which include the maintenance of circulatory flow and the pressure in the surgical patient. The illustration here, it's a graphical illustration of the experience of patients that are subjected to this enhanced recovery pathway compared to traditional pathway of care when aggressive 12 hours of fasting were not used, and the patient will allow at least clear fluid. Of course, physiologically, we know that within less than 1 hour, clear fluid will be will be removed from the stomach. So there is no risk of aspiration when patient is just allowed clear fluid, except there are some, underlying medical condition that will not allow that to be implemented, that will lead to delay gastric emptying. So this enhanced pathway shows that has demonstrated that there is less issues of that associated with either fluid overloading or fluid deficit in the perioperative patient. So, hemodynamic monitoring. Indication for hemodynamic monitoring. Hemodynamic monitoring is required in the following situation. Any deficit or loss of cardiac function, such as myocardial infarction, congestive heart failure, or cardiac myopathy. Any type of shock, such as cardiogenic shock, neurogenic shock, or anaphylactic shock. Reduce urine output due to dehydration, hemorrhage, burn, or surgery, which is our main focus. Mode of hemodynamic monitoring. There are two major modes of hemodynamic monitoring for perioperative practice. Non-invasive and invasive mode of monitoring of hemodynamics. Non-invasive monitoring method include non-invasive blood pressure and the pulse oximetry, which could be manual or use of multi-channel monitoring. Electrocardiogram, ECG, is also a very important tool that help to monitor hemodynamics, through giving us information about the cardiac reading through the graphical illustration that we see, in case of either ventricular tachycardia or supraventricular tachycardia. Those pathological abnormal heart electrical function will compromise hemodynamic of the patient in the intraoperative or in the perioperative phase of care, either pre or intra, although that we are often the most crucial part that we have, focusing on is intraoperative that phase, although the pre and also here about that things can actually accurately go wrong with the field of the interoperative. Any function is also, through monitoring of the usually output, expected volume of urine, very important of the indicator of non-invasive indicator of whether patient is receiving adequate perfusion into the kidney or is not receiving adequate perfusion, and it could serve as a early warning of acute renal failure. Then invasive blood pressure or invasive use of pulmonary artery pressure, arterial blood pressure monitoring. The most commonly used method of hemodynamic monitoring include use of multi-channel blood pressure monitoring, non-invasive blood pressure and the pulse oximetry, and then an arterial blood pressure monitoring. Arterial blood pressure monitoring, was one of the first hemodynamic variable that could be measured. Currently, different techniques are available for continuous and intermittent arterial blood pressure monitoring in the perioperative period. Arterial catheterization is the gold standard for measuring of the blood pressure continuously. When we have a situation that a patient is likely to either, the hemodynamic is subject to challenge through the massive potential loss of blood, or when there is need for deliberate hypotensive anesthesia, there is need to have arterial blood pressure monitoring in order to be sure to guarantee that while you are trying to induce hypotension, to induce that hypotensive state for successful surgery, to minimize blood loss, or to minimize blood loss and to minimize blood flow to the area of to the site of surgical operation. There is need to guarantee that there will still be sufficient blood flow to the vital organ. And the gold standard, the very important monitoring tools that can be used to ensure safety is use of these arterial blood pressure monitoring. For arterial blood pressure monitoring, a catheter is placed into a superficial artery, mostly radial artery. It can be brachial artery, or it could be femoral artery, and is connected via a fluid-filled tube to a pressure transducer and a pressure bag of fluid, which creates a counter pressure for arterial pressure. The pressure transducer transforms the mechanical pressure into electrical signal, which is used to depict arterial pressure waveform on the monitor. The signal that is picked up by the transducer is played as systolic and diastolic pressure on the monitor. The unit of arterial blood pressure monitor consists of the arterial cannula, the line and the saline pressure, transducer, and the monitor to pick up the signal that is sent by the transducer. And another important aspect of arterial pressure monitoring is mean arterial pressure. The acceptable mean arterial pressure ranges between 65 to 75 millimeters of mercury. In some situation where deliberate hypotensive surgery or deliberate hypotensive anesthesia is required, it could be allowance to be somewhere around 55, 60, depending on the discretion of the anesthesia provider and the response. Sometimes they work in synchrony with the experience of the surgeon at the site of the surgery, depending where they want the mean arterial pressure to be. But no matter how, you don't want the mean arterial pressure to fall below 60 to 55 to guarantee the perfusion of vital organs such as the brain and kidney. The common method that is used to, although most of these multi-channel monitor will display automatically, they display mean arterial blood pressure, but for the sake of students, I know we have some of us are students in the house. A common method that is used to estimate mean arterial pressure can be calculated with the expressed here in diastolic blood pressure plus 1/3 of the gradient between this systolic pressure and diastolic pressure. I mean, the 1/3 of systolic pressure minus diastolic pressure, or mean arterial pressure could also be classified, calculated with what by adding 1/3 of diastolic pressure to the 1/3 of the pressure that is deduced. So where diastolic pressure, in this formula, the diastolic pressure DP, sorry, the DP is the diastolic pressure, SP is the systolic pressure, PP is the pulse pressure. Pulse pressure is when you minus the diastolic pressure from the when you minus diastolic pressure from systolic pressure, it gives you the pulse pressure. This method is often more conducive to measure mean arterial pressure in most clinical settings, as it is often a quick means of calculating if the blood pressure is known. If you know the systolic or diastolic pressure, even if your device cannot give you automatic mean arterial pressure, you can be able to calculate that by yourself. Sorry, Robinson. Another means of invasive blood pressure monitoring, it's central venous pressure. Central venous pressure is measured by putting cannula into the vena cava. The central venous pressure is measured in the vena cava near the right atrium and is commonly obtained by placing a central venous catheter in the superior vena cava via internal jugular vein or subciliar vein. The catheter is then connected to a pressure transducer via a fluid-filled line. The central venous pressure is determined by cardiac function and venous return to the heart, and has traditionally been used to estimate preload volume to guide fluid therapy. It is assumed that because obtaining ventricular end diastolic volume was not suitable in many clinical settings, central venous pressure will be a surrogate measure of preload. Preload is about the volume of the blood that is in the heart before the ventricular contraction to push the blood into the systemic circulation before ventricular contraction. Although central venous pressure is not able to predict the volume responsiveness, it can be used to assess the right ventricular function, for example, in pulmonary embolism. It could also be used to assess right ventricular failure or after heart transplantation. Another advantage for using a central venous catheter is the possibility of taking blood gases, of taking blood for gas sample measuring in the central venous oxygen saturation. Illustration of course, some system use digital transducer, electronic transducer to pick up the pressure and transmit to the screen, while we still have the method that use water pressure to measure central venous pressure and the position in relation to the level of the heart. Another measure of hemodynamics element is pulmonary artery catheter. Pulmonary artery pressure includes the systolic and diastolic pressure, and the pulmonary occlusion pressure. Pulmonary occlusion pressure is also known as wedge pressure, wedge pulmonary pressure, and can be assessed by a pulmonary artery catheter. Pulmonary catheter have minimum of 2 ports, and one port can be used to inflate or deflate a balloon, the balloon at the close to the tip of the catheter. It's when the balloon is inflated that pulmonary occlusion pressure or wedge pulmonary pressure is measured. Internal jugular vein, subciliar vein, or femoral vein through the right atrium and the right ventricle until its tip is positioned in the pulmonary artery. The catheter is then connected via tubing to a pressure transducer to obtain pressure measurement. This pressure measurement can be used during insertion to assess the position of the tip. The catheter contains 2 or more ports. The distal port is located at the tip, and the other port is located more proximally and can be used to measure central venous pressure. Pulmonary arterial catheter contain a balloon close to the tip, which can be inflated to float the catheter into the pulmonary artery and to determine pulmonary occlusive pressure. The pulmonary occlusive pressure reflects the pressure in the pulmonary artery and vein. In conclusion, hemodynamic monitoring tool can be divided into two categories: invasive and non-invasive monitoring tool. The most invasive tool, pulmonary arterial catheter, can be used to assess multitude of hemodynamic variables. For example, carbon dioxide, pulmonary artery pressure, and cardiac output, pulmonary artery pressure, systemic vascular resistance, pulmonary vascular resistance, and the right ventricle end diastolic volume or ejection fraction, and so on. Many of the principles in the early recovery pathway have to improve and simplify perioperative fluid and hemodynamic therapy. With the rising popularity of ERAS, perioperative fluid management over the last several years has shifted away from liberal fluid therapy to more restrictive and a goal-directed approach. Alongside with these, there is an increase in awareness of relationship between intraoperative hypotension, increased postoperative complication, and maintaining adequate intraoperative mean arterial pressure is a critical component of care. Thank you very much for listening.
Okay.
Of course, sorry. Of course, I think I did not emphasize enough the need for observation. For instance, this non-invasive method of monitoring and our sense of observation, especially as nurses in the OR, especially when there is active surgery that involves active drainage of fluid from the body cavities, such as peritoneal fluid drainage or drainage of, most especially peritoneal fluid drainage or intra-abdominal fluid collection. There could be a kind of drastic fluid shift in this kind of situation, and monitoring the pulse rate and listening to the sounds of pulse oximeter sometimes can help us to assess when a patient is going into tachycardia, which is one of the earlier sign or earliest warning sign of hypovolemia, and the cardiac compensatory kick to compensate for the diminished fluid that is available in the circulation. Thank you very much. Let me just pause here.
Okay, thank you so much, sir. Thank you for the nice presentation. We'll be moving on to WhatsApp, so our WhatsApp group, TORG Nigerian WhatsApp group, so we can continue with our questions and answer session, and then